Welcome to our 11th session of the ECG course. Today we will delve into the intricate topics of pericardial, myocardial, and pulmonary syndromes. A vast spectrum of serious diseases can have a profound impact on the ECG, making it a crucial tool for diagnosis and monitoring. The conditions we'll focus on today are especially significant. These involve the pericardium, such as acute pericarditis, pericardial effusion, and chronic constrictive pericarditis, as well as the myocardium itself. However, please note, we will not be covering ischemia and infarction in this session, as these topics were extensively discussed in classes 8 and 9. Lastly, we will touch upon pulmonary conditions, including acute pulmonary embolism and chronic obstructive pulmonary disease. Join us as we navigate these crucial topics in cardiology, understanding their implications on ECG readings and patient health. Acute pericarditis refers to the inflammation of the pericardium, and it can stem from various causes. These include viral or bacterial infections, metastatic tumors, collagen vascular diseases, myocardial infarction, cardiac surgery, and uremia. In Class 8, we discussed how ECG patterns of pericarditis closely mimic those found in cases of acute MI. Acute pericarditis, especially in its early stage, is commonly characterized by elevations in the ST segment, a result of what is known as a current of injury pattern, triggered by inflammation of the epicardium, or the heart surface. This inflammation usually coincides with the inflammation of the pericardium overlaying the heart. A crucial point of differentiation between ST segment elevations in pericarditis and acute MI lies in their distribution. In an MI, these elevations are typically confined to the anterior or inferior leads due to the infarct's localized area. Conversely, the pericardium's role in enveloping the heart makes the STT changes in pericarditis more generalized, with ST segment elevations often observed in both anterior and inferior leads. An illustration of this can be seen in this ECG, where the elevations occur in leads D1, D2, AVL, AVF, and V2 to V6. Beyond affecting ventricular repolarization, the ST segment, acute pericarditis also has a profound impact on atrial repolarization, which commences during the PR segment, spanning from the end of the P wave to the start of the QRS complex. Notably, inflammation of the pericardium often triggers an atrial current of injury, as evinced by the PR segment's elevation in lead AVR and depression in other extremity leads, as well as the left chest leads, V5 and V6. Over time, the ST segment elevations in acute pericarditis may give way to T wave inversions, a sequence that parallels the one seen in MI. In some instances, the T wave inversions caused by pericarditis fully resolve over time, with the ECG eventually normalizing. However, there are also cases where the T wave inversions persist for extended durations. The resemblance between the ECG patterns of acute pericarditis and acute MI, especially with both conditions possibly leading to ST segment elevations followed by T wave inversions, warrants emphasis. It's worth noting, though, that pericarditis-induced STT changes are usually more diffuse compared to the localized changes associated with MI. Another distinguishing factor is that pericarditis does not lead to abnormal Q waves, as is the case with certain infarcts. This distinction arises from the fact that abnormal Q waves in MI cases are caused by the death of heart muscle and the ensuing loss of positive depolarization voltages. On the contrary, pericarditis typically only causes superficial inflammation without inducing actual myocardial necrosis, which means that abnormal Q waves never result from pericarditis alone. In certain patients, pericarditis episodes may recur or relapse, either intermittently or over sustained periods. The corresponding ECG findings can vary greatly, sometimes reflecting the characteristics of acute or evolving pericarditis. The presence of pericardial effusion may lead to low voltage, which will be further discussed. Pericardial effusion pertains to the abnormal accumulation of fluid within the pericardial sac. More often than not, this fluid buildup is a result of pericarditis. However, in certain situations such as myxedema or heart rupture, pericardial effusion can occur without the presence of pericarditis. One of the significant clinical implications of pericardial effusion is the potential for cardiac tamponade, a dangerous condition where the accumulating fluid chokes off the heart, triggering a drop in blood pressure and, at times, leading to cardiac arrest with pulseless electrical activity. A frequently observed ECG indicator of pericardial effusion, regardless of whether tamponade is present or not, is the low voltage of the QRS complexes. This low voltage is likely attributed to the short-circuiting of cardiac voltages by the fluid encircling the heart. The existence of low voltage is defined when the total amplitude of the QRS complexes in each of the 6 extremity leads is 5 mm or 0.5 millivolts or less. Low voltage in the extremity leads might or might not coincide with low voltage in the chest leads, defined as a peak-to-trough QRS amplitude of 10 mm or less in each of leads V1 to V6. Other factors, such as obesity, can result in low voltage due to the fat tissue located between the heart and the chest wall. Additionally, patients with emphysema experience increased lung inflation, causing extra air to insulate the heart. Among the causes of low voltage listed, obesity, anasarca, pleural effusions, and emphysema are the most common. However, upon encountering low voltage, particularly in conjunction with sinus tachycardia, pericardial effusion must always be considered due to its potential to progress into fatal tamponade. Electrical alternance is another crucial pattern that may manifest with pericardial effusion and tamponade. This pattern is marked by a beat-to-beat shift in the QRS axis in connection with the mechanical swinging of the heart to and fro amidst a sizable fluid accumulation. The presence of electrical alternance with sinus tachycardia is nearly diagnostic of cardiac tamponade, although not every patient with tamponade will exhibit this pattern. Certain conditions that lead to inflammation of the pericardium can further progress to fibrosis and calcification of the pericardial sac. Such conditions can be triggered by various factors, including cardiac surgery, physical trauma, and various infections such as tuberculosis, which is particularly common in developing countries, and viral infections that may go unnoticed in their acute phase. Other causes include malignancies, connective tissue diseases, sarcoidosis, uremia, indicative of renal failure, and asbestosis. However, in some instances, the cause remains unknown, classifying the condition as idiopathic. Patients suffering from these conditions often display symptoms akin to heart failure, with right-sided symptoms that disproportionately outweigh those on the left. Symptoms might include elevated neck veins and even ascites. This condition can sometimes be misdiagnosed as liver cirrhosis due to their similar presentation. In most cases, the treatment strategy involves surgical intervention, commonly involving a procedure known as pericardiectomy, where the pericardium is stripped away. This helps the heart to fill normally and reduces intracardiac pressures. Electrocardiogram patterns are not specifically diagnostic of chronic constrictive pericarditis. It is not uncommon to observe nonspecific STUS-T wave changes and low voltage. The PR and ST segment findings may resemble those of acute pericarditis. Additionally, atrial arrhythmias, including atrial fibrillation, may occur. Non-invasive diagnostic imaging tests can provide invaluable insights into the condition. These tests may include chest radiography, echocardiograms with Doppler recordings, computed tomography, and magnetic resonance imaging studies. Cardiac catheterization, accompanied by meticulous hemodynamic measurements for the balancing of diastolic pressures and the identification of characteristic venous waveforms, is an essential step in evaluating these patients before performing a pericardiectomy. Myocarditis refers to the inflammation of the heart muscle and can be associated with a variety of conditions, including certain viral infections. The range of symptoms and presentations in individuals with myocarditis is broad, with some individuals exhibiting no symptoms, while others may experience severe heart failure or even sudden death. In certain cases, myocarditis and pericarditis, another heart inflammation, may occur simultaneously. Electrocardiogram findings in patients with myocarditis can be quite diverse. They may display nonspecific STT changes or the repolarization changes that arise with acute pericarditis. In severe cases, the ECG findings might mimic those of an acute myocardial infarction, complete with initial ST elevations and subsequent development of pathological Q waves. Myocarditis can also lead to atrial or ventricular arrhythmias, as well as atrioventricular or ventricular conduction disturbances. Chronic heart failure, also known as congestive heart failure or simply heart failure, is a complex syndrome that can be attributed to various causes, including myocarditis, extensive MI, systemic hypertension, valvular heart disease, and cardiomyopathy. The ECG can offer helpful clues for diagnosis in some of these patients. Prominent Q waves and typical STT changes may hint at underlying ischemic heart disease with extensive infarction. Left ventricular hypertrophy patterns could signify hypertensive heart disease, aortic valve disease, stenosis or regurgitation, or mitral regurgitation. A combination of left atrial enlargement, or atrial fibrillation, and signs of right ventricular hypertrophy strongly suggests mitral stenosis. Left bundle branch block may be seen due to ischemic heart disease, valvular abnormalities, hypertension, or cardiomyopathy. Some patients may show marked enlargement and decreased function of the left and often right ventricle, despite the absence of coronary artery disease, hypertension, or significant valvular lesions. In such instances, the condition is termed dilated or congestive cardiomyopathy. The causes can vary, ranging from chronic excessive alcohol consumption, alcoholic cardiomyopathy, to viral infection, genetic predisposition, or some other cause. Patients with dilated cardiomyopathy, regardless of the cause, may exhibit a distinctive ECG pattern known as the ECG heart failure triad, which is characterized by relatively low voltages in the extremity leads, with the QRS in each of the 6 extremity leads measuring 8 millimeters or less in amplitude. Relatively prominent QRS voltages in the chest leads, such that the sum of the S wave in either lead V1 or V2 plus the R wave in V5 or V6 is 35 millimeters or more. Very slow R wave progression defined by a QS or RS-type complex in leads V1 to V4. The presence of the ECG heart failure triad strongly suggests underlying cardiomyopathy, but doesn't indicate a specific cause. The triad may occur with primary dilated cardiomyopathy, severe heart disease due to prior infarction, or significant valvular dysfunction. However, the ECG heart failure triad has only moderate sensitivity, meaning its absence doesn't rule out underlying cardiomyopathy. The electrocardiogram is not a highly sensitive tool for diagnosing pulmonary embolism. In certain cases, an embolus obstructing the pulmonary artery system may lead to noticeable changes in ECG readings, but there is no single, always diagnostic pattern. Various patterns may emerge, including sinus tachycardia, along with arrhythmias such as ventricular ectopy and atrial fibrillation. A right ventricular overload pattern, previously referred to as strain, characterized by inverted T waves in leads V1 to V4. The so-called S1Q3T3 pattern, which presents an S wave in lead D1 and a new Q wave in lead D3 with T wave inversion in that lead. This pattern, which may mimic that produced by acute inferior wall MI, is likely due to acute right ventricular dilation, shifting of the QRS axis to the right. ST segment depressions, which align with subendocardial ischemia. An incomplete or complete right bundle branch block pattern, displaying a wide RSR in lead V1. While the presence of these changes, particularly in combination, can suggest pulmonary embolism, they are not definitively diagnostic. Many patients with substantial pulmonary emboli may display only minor, relatively nonspecific ECG changes. Consequently, both the diagnostic sensitivity and specificity of the ECG for pulmonary embolism are limited. These findings may also arise from other causes of acute or subacute right ventricular overload, cor pulmonal, such as severe pneumonia or widespread pulmonary malignancy. Patients suffering from severe chronic obstructive lung disease, specifically emphysema, often display a relatively distinctive set of electrocardiogram findings. These include low QRS voltage, slow R wave progression in the chest leads, a vertical or rightward QRS axis in the frontal plane, and right atrial overload. The low voltage in the QRS complex is due to excessive trapping of air in the lungs. The slow progression of the R wave can be partly attributed to the downward displacement of the diaphragm, causing the chest leads to be positioned relatively higher than usual. In addition, right ventricular dilation may lead to a delay in the transition zone of the chest leads. Due to emphysema, the heart often assumes a vertically oriented position in the chest, which may, along with possible right ventricular enlargement, result in a vertical or rightward, plus 100 degrees or greater QRS axis. Moreover, the presence of tall, relatively narrow P waves is indicative of right atrial overload and is accompanied by a vertical or rightward P wave axis, approximately plus 90 degrees. Thank you for taking the time to learn with us today. Please share this video with your colleagues, subscribe to our channel, and give us a positive evaluation. We're excited to announce our upcoming class on Wolff-Parkinson-White pre-excitation patterns. This vital topic is essential for mastering ECG interpretation, and we can't wait to explore it further with you. We hope to see you soon in our next video.